stable before, through, and tube in a bariatric procedure. Meaning for an AG2, so nobody has stable through a tube, okay, there's at least one. Like, you know,
okay, let's take a look.
Only one person? You're transecting the nasogastric tube. Who in the room has transected the nasogastric tube? So at least just me and Charlie. Who in the room has transected the nasogastric tube before? I think the reason I ask is this is a preventable problem. And you really have to put a lot of effort with the whole thing. What's that? In any procedure that you operate on the stomach, you need to make sure this is mentioned to the operative team and to your anesthesiologist several times. You know, you need to talk. The only way to prevent it, because the time you transected it, it was not an AG2, it was a temperature probe. So we talked about the AG2, and the anesthesiologist said the temperature probe is only in the nose. But when we passed the tube down, that temperature probe went with it. The only way to prevent this preventable complication is to always mention every anesthesiologist who knew that this could happen. They need to make sure there's nothing except the AG2. Are you guys going to do endoscopy, Kelvin? Can you hear us?
Oh man, they just asked, left in the mirror, asked the audience, how many people have signaled across an NT2? And only one person raised their hand.
That would be,
No, that would mean most people are liars.
I did.
I see the outside view. Can you show us the
I
inside
used to
view?
say, if you haven't signaled off an NT2, you don't have enough experience.
Because everybody does that.
One time in their life. It doesn't matter how careful you are.
Can you show us the inside view where you can only see the outside view?
Wait, this could go better. You know this is better.
Trying to find something. Okay, thank you.
You didn't have to move again.
At the bottom?
Busy signal. I got no So, if my mic is on, I can't hear anybody in the room because my audio just went out.
We can hear you very well. Quick question: how are you going to test this sleeve, or should you test every sleeve?
Yeah, because it was towards you Saturday, huh?
Yeah. I like this one. It's the one that's over.
Who in the audience tests the sleeve gastrectomy at the end, either methylene blue with endoscopy, so almost everybody. Anybody in the audience does a sleeve gastrectomy and does not test the integrity of the sleeve? That's what you do not test the integrity of the sleeve.
With the 10 millimeter, that big one?
Yeah.
Who in the audience sees drains in the sleeve gastrectomy?
Check it out.
Okay. And who in the audience does not see drains in the surgery? Actually, more people need drains. What's the purpose for the people who need the drains? Can you guys get us the microphone? I would like to hear what's the purpose of the drain? Is it for bleeding or being how soon do you remove it?
I would always drain, and I usually take it out after the gastrocnemic swell. I do always the gastrocnemic swell. I know that the gastrocnemic swell is indicated for a leak, but it gives me an idea about the sleeve, gives me an idea about the passage of the gastrography going into the
get myself out the going, they're using it as a reactor. And you saw it using the wool dryer, and you go banging it into the fire.
Silicon gray, we control just the bleeding, working hard, sometimes nurses.
The fellow about the serious.
It's not for the purpose.
The real always.
I think first, like 20 hours after surgery is very important. Just for peace of mind. If there is any bleeding, to show up on the brain immediately. You don't have to wait until tachycardia and blood pressure accordingly.
I got a business.
So I rely on the brain possible, and usually I do in the third day was only milk testing. Just give the patient milk, and the thing is okay.
How about the use of upper GI studies? Who in the room does an upper GI study on post-operative day number 1? One, two. Okay. So I'd like to hear from both who do upper GI studies. How many times did the upper GI study help in the management of the patient? Either detecting a lead or detecting a lead. That's a microphone to Dr. Miller at the back.
Perfect idea. When can I start feeding? So if the study is low, I go fast track.
How to make a clinical one and maybe.
We are watching here the tour repair. Do you do that routinely or only when patients come from reflux treatment? Or do you do it routinely that you expose on the beta production side?
I tried my best to convince patients to have reflux against my house. This is the two indications that I push very hard for the person not to have to see are reflux and diabetes. For the rest, I just let them decide. On all cases, I expect the left, I expose the left fuse, and if I see what looks like a hernia, I'll come and explore. But I don't explore all patients, but I have a very low threshold in explore hiatus. I do have patients sometimes who refuse to have bypass, even though they have reflux. And those patients, we make sure they have endoscopy. They usually have the endoscopy because of reflux. And we are very aggressive in trying to move the hiatus. Posteriorly make sure that they have intravenous.
My question also goes towards, we know that the blood supply at the junction is poor, natural, physiological, and that we should not cut too much blood supply from the other side. So if you expose it from the right side, then you have to expose the hiatus from the left side. So why not just exposing the dura anterior and looking at them and see which are done?
You do it? Yeah.
The blood supply is coming from the left gastric. We do not overload the left gastric. So we expose the hiatus in the gastrointestinal from the left gastric and above. So we do not touch the blood supply in the surgery. It's still okay. Even when you revision surgery gastric bypass, we do not take the left gastric. Make sure always the left gastric. Here, because the patient had reflux. The patient did not have gastric bypass. Yeah, but it was a gastric first. Reflux gastric first. One more question to the audience. Who in the audience uses the combination of ondansetron, metoclopramide, and like two types of narcotics, like using for instance paracetamol, IV NSAIDs, this four combination, and dexamethasone at surgery, steroids, these 5 drugs. Who uses these 5 drugs at the time of surgery and afterwards? I mean, I tell you, if you don't use it and you have issues with nausea after surgery, this is the biggest advance that happened in anesthesia that allowed us to send patients home. So the reason in laparoscopic cholecystectomy we can send patients home is not because of laparoscopy. It's because patients do not develop nausea anymore after surgery. Something that was very common 20, 30 years ago. And it's because of those 5 medications. Using Decadron at the time of surgery, using Diprivan for anesthesia, using ondansetron, metoclopramide very, very aggressively around the clock in the first 24 hours, and using 3 types of pain medication: paracetamol around the clock, non-steroidal anti-inflammatory drugs, IV around the clock, and very little dose of narcotics. When you do use all those medications together, the incidence of post-op nausea and vomiting becomes very, very low. I mean,
a very important factor is to hydrate the patient very well. Because when the patient usually enters the OR, he is already fasting since, let's say, 12 o'clock at night. And then he comes into the theater at 4. So it's very important. I usually when the patient comes to the ward, the surgery, let's say, it's at 10, 11, I let them give them an infusion to the hydrate. This is very important for these patients that they are always well hydrated.
great point. One of the principles we learned from colorectal surgery fast track is you can allow your patients clear liquids up to 2 hours before surgery, and we do that. So the patients are allowed to have juice and clear liquids up to 2 hours before surgery. And this is using the anesthesia literature, because this is what allows for the fast track. So who in the audience uses fast track, meaning no nasogastric tubes after surgery, no Foley catheters, like they allow patients to drink as soon as they wake up. I think these things are extremely important. And that's why you need to test the integrity of what you do at the time of surgery. So once it looks good, then you can actually liberalize what they do. And this makes not only the length of stay shorter, but it makes the patient actually gets up and moves around. Especially with the Foley catheter. I was very dogmatic about it for a very long time. But then I stopped using it, and it's a very, very big difference when you don't place your catheters.
Physiologically, when the patient has a lot of tubes coming up, he is not encouraged to not be mobilized.
Kelvin, can you tell us what you're doing?
You're back. That's right. Okay. We're getting ready to do the endoscopy.
Okay. Can you show us the endoscopic picture?
We might be able to. I think we can. Oh no. Not for sure. Can we show the endoscopic picture?
I think we'll just use the regular room camera.
Yeah, we'll use the camera when we get ready with the. Hey, so did you guys prepare? Did my mic cut out too, or just the audio?
We can hear you, and laparoscopically the sleeve looks great.
Yeah, but yeah. What about the? Ooh, that's the steam. Okay. So did you? The only one person in the audience cut across an NG tube? That's all?
2 people, me and Charlie.
No one else has enough experience then. I think I've done it twice. Twice. So do you think it's a standard of care to do endoscopy post-op?
So we'll ask the co-moderators in the audience. Who thinks it's the standard of care to do endoscopy?
I don't think it's a standard of care. Mostly because I don't.
Okay, you can't answer that. Discount that. If you don't, why don't you?
Unfortunately not. I would love to have that, but that would raise the cost of the war. And I mean, we are in the private practice and getting a gastroenterologist down to do that. You're very lucky. I have seen you working. I would love to have that, but I don't have. Maybe in the future I will.
Any comments from the audience? Yes, Madam. Anyone does endoscopy at the end of the surgery? Yes, one person. Dr. Maher?
Previously, we were checking all the, suppose it was messing blue or air leak. But we found there is no advantage and there is no need for it. Or previously, we were doing routinely gastrographic swallow. There is no change in the line of management of the patient we have done before. So I stopped doing any check of procedure, any check of air leak, any gastrographic swallow. And there is no need for any pain in these patients. So, this is the usual trend. Sometimes we do steps we overdo and overtake patients. And we found our steps are not needed anymore, and so I will stop doing this type of procedure. So I don't believe endoscopy, routine endoscopy, will help in these patients unless you individualize your patient if you have any problem. Then this is a must to do endoscopy. If there's any, you divide the tube or you divide it and you found there's a narrow area, then the road is supported. So we cannot generalize or say this is the line of practice anymore.
Gilbert, let me clarify. I think that endoscopy is ideal, and one of the biggest regrets that I have is that I let my endoscopy privileges lapse. I think as a bariatric surgeon, it's a huge asset, and it's just like doing an intraoperative angiogram. The more you do it, the more comfortable, the more routine. So I think if you have the ability to do post-operative endoscopy routinely, absolutely do it.
I have a comment, then I'll let you ask a question. So the endoscopy in sleep, the purpose is not to look for a leak. The purpose is to actually look at stenosis. I mean, think about it. When your patient is in trouble and they're vomiting, they have problems, you will send them for an endoscopist to see if they're okay. Now imagine if you can do that on your own in surgery, and because you suture, you can actually do something about it.
Okay.
So the reason we're doing it is to look for not only leak, but for the way it's endoscopically, not only laparoscopically. And in the last 300 cases, we've had at least 8 or 9 patients, we're getting ready to publish this, where laparoscopically things look great. We go endoscopically, and the caesura, you cannot go through it. It looks blocked endoscopically. You remove the sutures, repeat the endoscopy, that block is gone. So that's the purpose of the endoscopy. And I think if you can do the endoscopy yourself, it becomes very beneficial. Because you learn more and more as you do it yourself. Yeah, thank you. Question, yes?
Actually, I'm doing my own endoscopy. I don't rely on physician or somebody else. But usually I agree with Dr. Hussein. It's not necessary to do in every single sleep. But I think I agree with you if you have a doubt. I think if you do your procedure in a proper way, then don't rely on endoscope to solve the problem. Like for example, bleeding or bile or something like this. I think if you do the procedure in a proper way, so no need to do the endoscopy as well. It will inflate the stomach and the cell.
One advantage that Keith mentioned is, bariatric surgeries is a changing field. And similar to how common bowel duct explorations became endoscopic procedures, a lot of things are going to move. And it's important for the bariatric surgeon to actually have that skill available. And also in revision.